As part of the state's emergency response to the COVID-19 pandemic, Governor Baker eased restrictions on the deployment of physician assistants that allowed more PAs to help with the surge of patients working in teams with other healthcare providers. To tell us about the change and how it helps with care and cost control is the medical director of the Respiratory Clinic at Cambridge Health Alliance, Janice John. Thank you very much for being with us, Janice.
To be here. Thank you.
Janice, a lot of people who hear a physician assistant, they might be a little puzzled. It's not exactly the physician. It's not exactly a nurse. So what is it exactly?
Right. So PAs are medical providers, and we provide care at all different points in the continuum of care. In my clinical practice, I am a primary care PA, and so I'm the one that'll see you if you have a sore throat, but I'm also the one that may see you if you have behavioral health needs or chronic disease or that kind of thing. But PAs practice in all parts of clinical medicine and on all sorts of clinical teams.
Well, you're involved maybe in diagnosis. You might spend a lot of time talking to a patient too, right?
Right. No, exactly. So we are able to diagnose and treat and prescribe and care coordinate. So provide connections to patients with specialty and that kind of thing. So we are absolutely able to do all of those things. And I think that the real value that we bring is being able to really be present with the patient and connect to them at the point of their need. So whether that's a patient who has cancer, it was the first time, getting the diagnosis, being able to just bear witness to and be present with the patient in that moment in time, or in the hospital. One of the PAs at BMC, who's a neurosurgical PA, will talk about how one of the most impactful. Yes, he participates in surgery, and yes, he does all of the things. But the most impactful thing that he does is really connect to patients in the moment that they or the families are very scared, very vulnerable, and I think that's where so much of our value lies.
Well, until recently, whenever a PA worked with a patient, there had to be either some kind of alignment with a top physician or some other kind of sign-off. How has the governor's emergency order changed that?
So the technical thing that's changed most significantly is it allowed us to be very flexible and nimble. So with all of healthcare right now, people are being redeployed into all sorts of different clinical settings. We have orthopedic surgeons who are calling patients with COVID results and being the folks that are that kind of first line of, hey, we want to share this diagnosis with you, and this is what it means, and this is what the social impact is. And that kind of thing. So we're all taking on very, very different roles. But what the executive order does for PAs is that order then doesn't need to go through a 1-month delay at the state level. So there was an older statute that meant that we would have to get a supervising physician change at that level, and then only participate in care in the way that supervising physician would be giving care. What is very interesting and challenging with COVID is that we're creating the evidence base as we go, and so there's not clear pathways. We all are becoming experts in COVID within a few weeks' time, and so we need to be really nimble and adaptable in how that all plays out. And so for me, for my role, I am the medical director of this respiratory clinic, which is an interprofessional clinic. We have family med docs and internists, and we have an ortho PA on our team who had a wonderful background in primary care that had been working in ortho for a few years, and we pulled her back in because she, one, speaks Spanish, and two, is a phenomenal PA, but also able to be a part of this team. And because we weren't doing orthopedic surgeries, it was much more important for her to be able to have an impact in our outpatient strategy versus some other role.
Well, I imagine, in a way, every patient at all times is a learning curve, but how is the learning curve with coronavirus different?
I think the learning curve for coronavirus is very different because for a number of reasons, but I will highlight for a moment the learning curve in outpatient, just because that is where I have been spending the past 6 weeks. So what's different in coronavirus is that you've got this clinical disease that we know not that much about, but it's embedded in all sorts of supply chain disruptions and also in different ecosystems. And so in China, what happened was that most patients, once they became symptomatic, were automatically quarantined, isolated. They were effectively admitted to a hospital-like setting. That, for many, many reasons, is not either practical or efficient in the US. And so we have, in the state actually more broadly, but certainly at Cambridge Health Alliance, we've heavily invested in an outpatient strategy where patients get a longitudinal set of care where they're able to be seen in a respiratory clinic, but then followed by community managers. But the biggest thing is there was no handbook at all for outpatient management of COVID, and we didn't know what's going to be safe, what's going to be not safe, because there was nothing written for clinical guidelines for outpatient management. Our team actually worked to put together the clinical guidelines for up to date, and for we've already disseminated a couple of pieces in Mayo proceedings and whatnot, because there were no pathways. We really needed to create those as we went.
We often talk about outpatient treatment, meaning after somebody's released from a hospital. But here, I think it could mean before you need more acute care and making sure you get something before it's really bad. Isn't that the case?
Exactly right. So Massachusetts, as you know, has been very forward thinking in building robust primary care. And in building robust primary care, and PAs have been a big piece of that, but in building robust primary care, most of the health centers actually work together to build some sort of outpatient strategy. So basically being able to see patients early in their symptomatology, risk stratify, understand which patients are most likely to get sicker or have a poor outcome, need hospitalization, potentially ventilation, and work to care for those patients in the outpatient setting. So what that looks like at CHA is that we have an outpatient clinic that sees somewhere between 80 and 98 patients a day. They are all patients who have developed some degree of shortness of breath. And when we see those patients, we're really evaluating, do you need to go to the hospital, or are you able to be cared for at home? And in being cared for at home, what else needs to happen to keep you safe? So in our case, we also have what's called a community management strategy, where physicians, PAs, and nurse practitioners are calling to check up on the patient on a daily basis to see if there's a change in their shortness of breath, a change in their dyspnea, as we call it. And so what we're doing actually is managing a lot of patients in an outpatient setting that would have been managed at home, in a hospital or in a hospital light in China and Singapore and whatnot. And so one of the things that I think has happened in Massachusetts is that one of the ways that we've actually been working to bend the curve, but also increase the total capacity of the health system, is by having these effective outpatient management strategies, tucking patients in with case managers, checking on whether they're getting sicker, and also asking questions about what are your barriers to caring for yourself during this disease? Who else is at risk? So also having the conversations about quarantining. And so every conversation that we have in our respiratory clinic, we're also asking, who else do you live with? Might they be at risk of getting COVID? So, we can contact trace, we can do all that, but I think the real way that we bend the curve, the real strategy, is a systems approach where we're able to be asking those questions and giving people advice about quarantining. And if the grandparent is the only option for caring for your child, we actually need to really think about that, because the grandparent is much higher risk of a poor outcome if they were to become ill. So,
well, you're a director at a new care center, for respiratory problems. It's a crisis response, but it's also a laboratory for going forward and doing things differently. What do you see going forward?
What I hope for, I think that what I have seen in healthcare in 6 weeks is absolutely remarkable. I find so much joy every day in getting to work with team members in a different way. We huddle with our community managers, and we're talking with the neurologists and the orthopedists and whatnot. We are teaming in a way that I've never seen happen in healthcare before. Healthcare is incredibly siloed, and that results in poor outcomes for patients. So one hope is that we start to make decisions about who works in what way based on the skill sets that people have, based on what they bring to the table, and not based on how we've been doing it for 30, 40, 50 years. I think that that's one thing. And then I think too is we've seen remarkable relationships between team members that had never worked together before come out of this. And what I'm hopeful is that we're able to, my hope is that that's kind of transformed our identity as team members, as providers. I hope that we will think very differently about what value is in the coming days ahead. I hope we will team better. I hope we will work together in a much more effective way down the road.